Okay, so here we start. It is being shown here. You can see this is a common gas outlet, and there is a tube and a rubber bulb has been attached to that, and the rubber bulb has been collapsed and it is remaining collapsed. What are we trying to find out?
Leak test, sir.
Yeah, it is called their universal leak test. Okay, so it is also known as the pressure leak test. So any internal leak in the anesthesia machine, even without opening the flow meter, sometimes there may be leaks inside the machine. So what you do is, how to do this test? Any idea? So how is it done? Step one is switch the machine into off position. Even the power mode should be in off position, and all the flow meters, all the cylinders, everything should be in off position. Okay. Then keep the flow meter and vaporizers also in off position. Attach a suction bulb with a rubber tube adapted to the common gas outlet like this, and then squeeze that suction bulb a few times to collapse it. Okay? And the bulb should remain collapsed at least for a minimum of 10 seconds. It should not get reinflated. If it remains collapsed, that means there is no fresh gas flow which is leaking and coming out. So if the bulb remains collapsed like this for 10 seconds, that means there is no internal leak happening in this machine at all. So this is a very commonly asked question in the examination. So you should be quite aware of this. And majority of the hospitals, they have this attachment ready in the drawers of the anesthesia machine itself, so that you can on and off check for the internal leak happening in this. So this is the what is shown here. Have you ever used this breathing system in your practice? Especially head and neck surgery or onco surgeries where you do a free flap for head and neck. This circuit is very, very commonly used nowadays. None of you have seen this?
No, sir.
Yes or no?
No, sir.
No. Why don't you just answer that? That's what I want. The single limb breathing circuit, also known as limb O breathing circuit. Okay, so this is the, instead of the two tubes which come for the inspiration and expiration in the normal way, this is a single tube which carries both the inspiratory and expiratory. So instead of that second tube coming from the expiratory or inspiratory limb, there is a Y limb which is an elbow connection like thing which is attached. And this is how it will be attached to the outlet. Normally you will have a double tubing coming, one for inspiration or one for expiration. So instead of that, this is a very ideal tube for head and neck oncology surgeries where you do a free flap and reconstruction and all that. So the hassle of having two tubes running over the patient will not be there. And this will have an internal tube and an external tube. Just which other tube has a coaxial circuit like this?
Vein circuit.
Vein circuit, very good. So vein circuit, which we are all aware of, it has got a, which is the fresh gas flow delivery tube, inside, internal tube or external tube in vein circuit?
Internal
tube.
Internal, green. That's why it will have a green color. Okay, so the internal tube is the inspiratory limb. So this is how it is attached to the machine, and it shows the way this picture shows the way the circuit is attached to the machine. Okay, and what are the uses of this? The single limb can be function as an anesthetic circuit as well as a Mapleson type deep breathing circuit. and as non-rebreathing circuit also as an ICU ventilator in adult and pediatric population. Therefore, it qualifies as universal breathing circuit. It can be used for both adult and pediatric and both as rebreathing as well as a circuit system. So comparing the single limb and vein circuit, which both are coaxial circuits, just like you can see here also the blue color is the inner tube and the white corrugated tube is the outer tube. So the design is vein circuit is a coaxial inner fresh gas flow and outer expiratory limb, whereas here single limb is a coaxial circle system that will be attached to the soda lime, and it will come function as like your regular circle system with the two limbs. And ventilation and flow rates, semi-open system. This vein circuit is coming under the classification of semi-open system, so it requires a higher fresh gas flow. Whereas this single limb breathing circuit is connected to the CO2 absorber, so you can use the low flow as you are using with the double tube system itself, circle system. And the differences in clinical hazards is inner tube of the vein circuit is susceptible for kinking or disconnection, whereas here they are all nicely sealed, so there is less chance of any disconnection. The advantage of vein circuit is it is lightweight, less drag on ET tube, and used for both adult pediatric as well as for MRI investigation. Similarly, the single limb is also compact, cost effective for prolonged use. So that these are more or less similar advantages for both the circuits. Name 3 maneuvers used in anesthesia practice and explain each one of them. What are the maneuvers you have used or heard about? Have you heard of
Chin
Larson's
lip jaw
maneuver?
thrust. Yes, sir.
What is it used
Larson's,
for?
to relieve laryngospasm. Sir.
Laryngospasm. Okay.
Yes, sir.
Any other maneuver?
That chin lip jaw thrust. Head tilt, chin lip jaw thrust, triple maneuver. Used to open the
Bailey's
airway.
maneuver. Have you heard of Bailey's maneuver?
Yes, to replace the ET tube with LMA during
with LMA
extubation.
under deep plane of anesthesia before
Yes.
planned extubation to avoid coughing and straining, especially in neurosurgical procedures where you don't want the increase in intracranial pressure to happen. Okay, so
Yes, sir.
this is how you do that. Patient is already having an ET tube connected to the breathing circuit, and this is the corrugated adapter for the endotracheal tube. So you insert the LMA behind the endotracheal tube, inflate it, and then connect the circuit and make the patient breathe through that and remove the AT tube. When the patient is already under deep plane of anesthesia and muscle paralysis, so that there will be no coughing or bucking during recovery. The second is what is called the Chandy's maneuver, which is a two-step airway technique used to optimize the blind endotracheal intubation through an intubating laryngeal mask airway, which is also called the fast track. So this is the method of intubating through a fast track LMA. So if you are not able to pass the endotracheal tube, you have to make a few adjustments by lifting this fast track and then trying to push the tube so that the tongue is lifted up nicely. So that is called the Sandy's maneuver. And Larson's maneuver is the bilateral firm digital pressure on the styloid process behind the posterior MS of the mandible. And it's nothing but an essential vigorous jaw thrust. And this helps to relieve the laryngospasm. So this is called the laryngospasm notch. So this is where you put your finger and push the jaw anteriorly as much as possible to relieve the laryngospasm. So these are the three maneuvers: Bailey, Chandy, and Larsa. What is being done here?
Ankle blocks.
Ankle block, right, but which nerve they are blocking in the ankle block? Looking at the foot, this is the big toe, this is the medial malleolus, so this is the tendo Achilles. So between the medial malleolus and tendo Achilles, which nerve goes to supply the foot? What are all the nerves which you have to block for ankle block?
Uh,
Tibial, superficial, and
Tibial nerve, saphenous nerve, superficial and deep peroneal nerve, and sural nerve. These are the
superficial
five
and
nerves
deep
you have to
peroneal
block.
nerve,
Okay?
sural nerve.
So posterior tibial or tibial nerve block using ultrasound guidance is what is being done here. What are the nerves to be blocked for ankle block? These are the five nerves: tibial, it is also called posterior tibial, superficial peroneal, saphenous, sural, and deep peroneal nerves. So what are the indications and contraindications for ankle block?
Toe amputation, sir. Indications.
Surgeries on the foot and toes, you can say like that. Okay. So all types of foot surgeries can be carried out with the ankle block and used for diagnostic and therapeutic purpose in spastic equinovarus and sympathetically mediated pain. So it can be used for chronic pain relief also. Contraindications, because motor block of the proximal leg and calf is avoided. Another advantage, ankle block may be preferable for outpatient for foot surgery. Now, can you perform ankle block for this case?
no, sir.
Why?
Active source of infection, open injuries.
So, whenever there is a infection, it is contraindicated. Ankle block should be avoided in patients with local infection, edema, burn, soft tissue trauma, or distorted anatomy with scarring in the area of the block. Is nerve stimulator useful in doing ankle block?
No,
Can you use a nerve stimulator to identify these five nerves and give the block?
Yes, sir.
no, sir. No,
Yes or no? Somebody
no,
saying
sir.
yes, somebody saying no. If supposing yes, why you say yes? If supposing no, why you say no? You cannot use because most of the nerves are sensory nerves. They don't have a motor component. Only if you have a motor component, you will see the motor contraction and response would be there for nerve stimulation. Okay. So sensory nerves, you will not have any motor response. So it will not be useful if to use this. So name the nerve supplying the sole of the foot. You have got the picture of the sole of the foot, and you have some various markings here. What are all the of the five nerves which are all the ones which supply the sole of the foot?
The
Which is the
heel,
major nerve
heel
supplying
is
the sole?
heel is heel is supplied by the calcaneal branch of tibial nerve.
Calcaneal branch, very good. And these are all
And medial
plantar
3.5.
branches. And what is
Yes,
this
sir.
particular thing? This the small area between the web between the first and second toe. What nerve supplies this?
Sural nerves.
Deep
Sural.
sural nerve is only the lateral aspect. Okay. So deep peroneal nerve supplies the web space between the first and second toe. This is the deep peroneal nerve supply. Core and middle sole is supplied by plantar nerve. Lateral supplied by the sural nerve. Posterior calcaneal area is supplied by the calcaneal nerve. So this is calcaneal, this is plantar, this is sural, this is deep peroneal. Okay, so this is how the soul supply is happening. A case of long-standing retrosternal goiter patient developed breathlessness and stridor following extubation. What is the diagnosis? This is a laryngeal bronchoscopic view. Here you can see.
Tracheomalacia, sir.
Malaysia, sir.
Tracheomalacia.
Fantastic. Tracheomalacia. So this is a normal trachea with the carina and the right and left bronchus openings. Okay. Here you see the tracheal wall itself is collapsed. So this is the case of tracheomalacia. Very good. Mention few complications of thyroid surgery.
Or recurrent laryngeal nerve injury and
Very good.
hematoma
Very good.
formation
Very good.
and hypocalcemia.
Very
Accidental
good.
use.
Very good.
Mm.
Excellent.
Laryngeal
So
edema.
laryngospasm, uni or bilateral laryngeal nerve injury, hematoma, hypocalcemia, and trichomalacia are all complications. What is the risk factor for this complication? That is the trichomalacia.
Due
Long-standing
to
goiter.
Long-standing pressure over the tracheal cartilages causing ischemia and softening of the tracheal ring, which collapse after extubation. Why that collapse is not happening when the patient is conscious? Why it happens only after you remove the now after surgery we are completely removing the gland, isn't it? Weight is
yes.
taken away. But a tracheomalacia patient, how will he exhibit there is a collapse in the pre-anesthetic or pre-operative phase? When will he have the symptoms of collapse?
Expirations.
During awake state or during sleeping state? What is the
Awake
key you have to
awake
elicit?
still.
Huh?
Sleeping.
Only when he sleeps he will have the obstruction. So majority of patients who have a huge thyroid will usually sleep on the lateral side because the weight of the gland will be taken away from the soft tracheal rings and it will be patent. When they lie on supine position, the weight will pressure over the trachea and collapse it. And they will wake up with a startling like obstructed sleep apnea patient. They will wake up and over a period of time they avoid sleeping on the back supine position and always go to the lateral side. So one of the important history you should ask the patient with long-standing huge goiters is their posture during sleeping, whether they sleep on their back or on the sides. If they sleep routinely on the side, that means already they have developed symptoms of tracheomalacia, which should be a clinical way of identifying this condition. Okay? And why it happens even after you remove the gland is the strap muscles are holding the gland and weight is taken away from the trachea during conscious state. When the patient is semi-anesthetized or sedated and some of the strap muscles are being cut during surgery, there is no protection. So the trachea collapses. Okay? That is the reason why the tracheomalacia happens even after removing the gland. The strap muscle support is lost. Now, another question is a 25 years old primee with 36 weeks of gestation suddenly collapsed in the ward and is hemodynamically unstable. EKG monitor shows ventricular fibrillation. What is the immediate action to be done by the anesthetist?
Defibrillation.
Huh?
Start CPR.
Fibrillation.
So start CPR immediately.
This is a
And
very important catch question here. 36 weeks of gestation. So the uterus is
manual
quite
left
enlarged.
uterine displacement. Manual left uterine displacement to be
Left
done.
uterine displacement or turning the patient to lateral and immediately starting CPR. Okay, that is the first and foremost thing that you have to do. Start chest compression as per Cole's protocol and organize for defibrillation and also do a left uterine displacement. What is the main difference between ACLS in a pregnant and a non-pregnant patient? Here, gravid uterus will compress the major vessels, so it must be removed by lateral position or manual displacement. What is the stipulated time for perimortem cesarean section? Supposing return of spontaneous circulation does not happen, within how many minutes you should do the cesarean section?
5 minutes, sir.
Within 4 minutes, and baby should be out before the 5th minute. Okay, within 4 minutes of maternal cardiac arrest and delivery targeted by 5th minute. How to treat ventricular fibrillation?
Immediate defibrillation if it's shockable with them.
First, always check whether patient is hemodynamically stable or unstable. Okay?
Yes, sir.
Then it requires high quality CPR and rapid defibrillation. Majority will be unstable only, but always check whether you have any palpable pulse or BP. Then immediately start high quality CPR and do rapid defibrillation. Morbidly obese patient, BMI 42, have a AHI, that is apnea hypopnea index of more than 30, posted for gastric sleeve resection surgery. What are the factors causing physiologically difficult airway?
Hypoxemia and known cardiovascular complications preoperatively. And
What is the difference between anatomical difficult airway and physiological difficult airway?
and anatomical difficult airways based on the patient external features
Structural.
like Malampathy grading and
Very good.
large
The factors
trunk
causing
features.
physiological are severe hypoxemia, hypotension, RV failure, aortic stenosis, mitral stenosis, cardiac tamponade, hypermetabolic state, and raised intracranial tension. So all these things lead to physiologically difficult airway. The reasons for rapid desaturation during apnea in a morbidly obese patient. What are all the reasons?
Reduced FRC
FRC.
and
Atraumatic
elevated
splinting,
diaphragm.
basal atelectasis,
Yes.
respiratory depression due to anesthetic agents. How to do ERAS for this particular surgery?
Early mobilization and
Start from the preoperative or pre-anesthetic fasting state.
yes, sir.
Early mobilization is after surgery,
After
but the
surgery,
ERAS
yes.
starts from preoperative counseling.
Yes.
Isn't
Weight
it?
reduction,
So,
adequate weight reduction
free
prior to
of
surgery.
counseling, weight loss, lifestyle modification, fasting and carbohydrate, intra-op, opioid sparing anesthesia, goal-directed fluid therapy, anti-nausea medications, minimally invasive surgery. Okay. And post-op, adequate pain relief, early oral intake and hydration, and early mobilization. So you must classify like this. Whenever they ask about ERAS protocol, must be
Yes, sir.
classified as pre-op, intra-op, and post-op. What are the components of metabolic syndrome?
Hypertriglyceridemia and obesity
What type of
and
obesity?
central obesity.
Central obesity. Yeah, you must be very
Yes, sir.
specific about it.
Yes, and reduced HDL cholesterol and elevated blood pressure of more than 130/85 and elevated fasting blood glucose more than equal to 100 mg per deciliter.
Insulin resistance. Okay, it's called
Yes,
so
sir.
central obesity, hypertension, insulin resistance, low HDL, and increased triglycerides. So any three of them will be qualifying for metabolic syndrome.
Yes, sir.
A known COPD patient, this is another case scenario, comes to ER with acute breathlessness, and the ABG done shows the pH of 7.31, CO2 55, PCO2 58, bicarb 30, and lactate 2.8. How do you interpret this AB?
Acidosis.
What type of acidosis? There are two types, isn't it? Respiratory and metabolic.
Is increased. So bicarb is 30. It's respiratory acidosis, and also lactates are elevated.
Hmm.
Along with it, we have hypoxemia. POT is only 55 millimeters of mercury.
Hmm.
Having hypoxemia also, sir.
Hmm. So pH is 7.31, which qualifies for acidosis. PO2 is low, PCO2 is high, bicarb is high, lactate is high. This is the value wise. So it's a case of acute respiratory acidosis with hypoxemia. Is there any compensation?
Uh,
The diagnosis is an acute respiratory acidosis with hypoxemia. What is the compensation that is happening here? Is the bicarb normal?
increase in bicarbonate.
So body is trying to retain bicarb to correct this acidosis. But is it a full compensation?
No, sir.
For
For
when will you
every
say it is a partial compensation and not a full compensation?
pH is not brought to normal.
pH is not returned to within the normal range. Then it is called partial compensation.
Partially
So
compensated.
bicarb alone is trying to compensate, but pH is not corrected, hence it is partial compensation. And what type of respiratory failure is this?
Type 1.
Type 1 now. PCO2 is also high.
Type respiratory.
So it is type 2 on both hypoxia and hypercarbia. Okay. If only hypoxia, then it is type 1. What is the significance of lactate here? What does it indicate? Raised lactate.
Metabolism was turned into anaerobic metabolism happening.
Anaerobic metabolism. Because of hypoxia, there is
hypoxia.
anaerobic metabolism. Very good. That is the answer. A 92-year-old female with multiple comorbidities and history of polytrauma and ventilatory failure supported by mechanical ventilation. Tracheostomy done, but weaning attempts are not successful. So what are the components of palliative care? Pin drop silence. Okay.
Pain, pain management and psychological counseling.
So pain
And
and
able to
symptom
support the
management,
families.
number one, good. Then psychological and emotional support, good. Then spiritual and extension care, communication and shared decision making, and care coordination, and family and bereavement support. Okay, these are all the components of palliative care. What is life-limiting illness?
The duration of the duration of life is limited due to the chronic diseases like
There's
cancer.
no cure. Okay, so a life-limiting illness is an incurable, progressive medical condition that has little to no prospect of cure and is expected to shorten a person's lifespan. This is called the life-limiting illness. So incurable disease, which is also progressing, and it has no prospect of cure at all. That is the life-limiting. What are the indications in the above patient? That is the patient who was on ventilator, which qualify for life-limiting illnesses. Patient has multiple comorbidities.
Multiple
They
comorbs
have
and polytrauma,
and are on ventilator support. You are
tracheostomy.
not able to wean the patient. So, what are all the things that make you think that this patient is going in for life-limiting illness? So, age, advanced age, multiple comorbid conditions leading to multi-organ failure, inability to wean from ventilator support. All these things qualified to make this patient be called as life-limiting illness. What is Spike's protocol and what are all the components?
Spike's protocol is for breaking the bad news, and it stands for S for setting, P for perception, and I for invitation, and K for knowledge, and E for emotions or empathy, and S for strategize or summarize.
Murray and Satterwhite. Okay. So, the six-step clinical framework used by healthcare professionals to deliver difficult or distressing medical news, such as cancer diagnosis or no hope of recovery, like that, and compassionately and effectively. So that is the acronym. So S is for setting, prepare the environment. Perception, assess the patient's current understanding of their condition. Invitation, ask the patient how much detail they want to know. And knowledge, deliver the medical facts clearly without using medical jargon. Empathize with the patient, allow the patient to process the news and respond their emotions like crying or staying quiet or calm, like that. And summarize and strategize, outline the next steps and treatment after. So this is an acronym collected from all these six things which goes to form the spikes. Identify the procedure done here.
Celiac plexus block.
That's part of the answer. On Osce, always you must try to give a complete answer to get the full mark.
Ultrasound.
Where is the ultrasound probe?
No,
Is not shown
no,
here
sir.
at all.
No, sir.
Is it done on one side or both sides?
Bilateral.
Both side, bilateral.
That
Bilateral.
is very, very important. The bilateral celiac plexus block. Two needles are shown here. Okay? If it is only one needle, you can say celiac plexus block. But needles are put there, you must say it is always bilateral. Name two approaches for this block.
Central approach.
You are right. Posterior and anterior. Para-aortic approaches. Okay, it is called posterior and anterior para-aortic approach. What is the most common indication for this block?
Any
Intractable
like
pain
gastric
due to
procedures.
CA pancreas. Yeah,
Yes,
intractable abdominal pain mainly due to CA pancreas is the most common indication. Mention few complications of this procedure.
Hypotension, diarrhea.
Because you are very closely going to the major vessel. So what is the first and foremost thing you must say?
Bleeding, sir, bleeding.
Injury to vessels,
Damage,
bleeding,
arterial puncture.
intravascular injection, okay? Paraplegia, infection, and abscess formation. What is shown here?
Pressure volume loop curve. Pressure volume loop curve of
pressure volume loop in the case of
mitral regurgitation.
Mitral or aortic?
Aortic. Sorry, sir.
Aortic regurgitation. So ventricular pressure volume loop in aortic regurgitation. Okay. What factors affect a ventricular function?
Preload, afterload,
Preload, afterload, contractility,
ventricular contractility.
rate. Okay. So ventricular function is primarily preload, afterload, contractility, and heart rate. These are the 4 factors which affect the ventricular. What are the goals in anesthetic management of a patient with aortic regurgitation coming for surgery?
We have to maintain the sinus rhythm and avoid tachycardia and
Avoid tachycardia. Regurgitation.
sorry, sir, I am saying for mitral, sorry.
So aim is to maintain forward flow and minimize regurgitant volume. This is the first and foremost aim. To achieve this, you slightly increase the heart rate, adequate preload, low to normal systemic vascular resistance, and normal contractility. These are the 4 things that are required to maintain the normal. What is shown here and what is the diagnosis?
Sausage points. Sausage points.
Sausage points. Okay. First of all, what is shown here in Nagaswamy? This is a rhythm strip, EKG showing abnormal rhythm. And what is the diagnosis? That is polymorphic ventricular tachycardia. Mention the causes of ventricular tachycardia.
Any electrolyte abnormalities like hypokalemia, hypomagnesemia, any drugs like antipsychotics, ondansetron.
Ondansetron produces tachycardia. So scarred heart tissues like previous heart attacks, coronary artery disease, or prior heart surgeries, structural heart disease like heart failure, cardiomyopathy, or myocarditis, electrolyte imbalance of potassium, sodium, calcium, and magnesium, medication and substances like antibiotics, use of illicit drugs like cocaine and methamphetamine, inherited disorders like congenital long QT syndrome. These are all the various causes of ventricular tachycardia. How is it treated?
If a patient is unstable or stable, sir, if the patient is stable, we can give a IV magnesium sulfate, sir. And we have to stop any drugs which causes QT prolongation. And
So
if
check
the
whether
patient
the
unstable,
patient is hemodynamically
defibrillate.
stable or unstable. That's the correct answer. If stable, treat with drugs like IV lignocaine, procainamide, amiodarone, and correct electrolyte imbalance. And if unstable, pulse
Defibrillation.
synchronized electrical cardioversion followed by antiarrhythmic drugs. And pulseless ventricular tachycardia treated as cardiac arrest, immediate CPR, defibrillation, advanced cardiovascular life support protocols. What is shown here?
The airway assessment, the 332 rules, sir.
Yes, good. Called the 3-3. Testing the 3-3-2 rule for difficult airway assessment. What is measured in each test? You have A, B, C as named as
3 is first one is a mouth opening, second one is thyro-mental distance, third is the io-mental distance.
Third is hyomental. The mentum is here. This is this is mento-hyoid distance, not thyromental distance.
Mento-hyoid.
Hyoid. So A is 3 fingers inserted to check adequate mouth opening. B is 3 fingers used to measure the mento-hyoid distance. And C is 2 fingers used to measure the thyrohyoid distance. The distance between the hyoid bone and the thyroid bone, thyroid cartilage. Okay.
Yes, sir.
What is the mouth opening needed for LMA insertion?
2 finger, more than
Minimum
2
2 centimeters. An inter-incisor centimeter distance of 2 centimeters generally required, but the 2.5 to 3 is ideal for placing the device easily and ensuring proper pharyngeal seal. What is inferred by doing the upper lip bite test?
It's it it is the bedside test for ruling of difficult laryngoscopy and intubation.
No, what do you infer by doing the test? What is the purpose of
It evaluates that temporomandibular joint mobilities.
mobility of lower jaw,
Yes,
neck
sir.
alignment, and teeth alignment? Okay, it
Yes, sir.
assesses patient's jaw mobility, neck anatomy, and teeth alignment.
Yes,
All
sir.
the 3 are. What is shown here, and what is the description given for this shape?
Omega shaped epiglottis.
Who has this sort of thing? What is
Pediatric
this?
age group.
It is the epiglottis in an infant. Okay? It
Yes,
is an
sir.
infant epiglottis, and it is described as omega shape, which looks like this. Okay?
Mhm.
Mention 4 differences between adult and pediatric airway.
Uh,
Only 4 differences.
in adults, in pediatric, the narrowest part is the subglottis, and adults it is the glottis. And pediatric, they have larger occiput, and larger tongue. The
Yes.
pediatrics will have larger tongue,
Very
so the
good.
risk of obstruction is high. And
What about the level of the larynx?
level of larynx is higher in case of in C2, C3, and in adults it is around C4 to C5.
So higher and more anterior larynx, C3 to
Yes, sir.
C4 in infants, C4, C5 in adults. Funnel-shaped subglottic region, which is narrowest part is the cricoid cartilage, and the vocal cord at the adult glottic region. Relatively large tongue in relation to oral cavity, larger head and occiput causing natural flexion of the supine in children. Which is the type of blade preferred and why it is preferred for intubating an infant?
Miller's blades, sir.
Miller's blade is
Infants.
same, but what is the description? Is it a curved
It
blade?
is a straight
It is a
laryngoscopy.
straight blade used to include the epiglottis while lifting in the tongue. So that is the reason why we use the straight blade. And the name 2 blades which are used for infant intubation. One is already you have said
Miller's
Miller's,
blade.
and then there is another
Also,
called Forager. These are the 2 blades.
Forager.
Patients with progressive dyspnea, increased work of breathing, has an ABG done which shows a pH of 7.34, PaO2 68, PCO2 55, on FiO2 60%. Identify the clinical condition and interpret the ABG. This X-ray, you must identify which condition it will be like this, and make your interpretation of the ABG values. This already, I think we have discussed in
Yeah,
the last.
bilateral opacities over
Infiltrates are there.
infiltrates,
So probably
ABG,
case
ARDS,
of
sir.
ARDS. This is the case of ARDS. What is the interpretation of the ABG?
Re- Respiratory acidosis.
Respiratory acidosis. pH is only mildly decreased,
Yes,
7.34,
sir.
which is grossly bad here.
Hypoxemia.
Hypoxemia when a patient is on 60% oxygen. Okay,
Yes, sir.
ABG shows type 1 respiratory failure because
Yes, sir.
PCO2 up to 55 is normal, 45
Yes,
to
sir.
55
Yes,
is
sir.
the normal range, isn't it?
Yes, sir.
So this is a classical case of type 1 respiratory failure. What is PF ratio in this case and how does it help?
PF ratio to know the severity of ARDS.
So
If
how
it
to
is
calculate the
mild,
PF ratio value?
by determining the arterial oxygen partial pressure divided by fraction if a fraction of inspired oxygen,
Hmm.
we can calculate based on severity as mild, moderate, and severe. Mild is between 200 to 300, moderate is between 100 and 200, and severe is less than 100. Lower PF
So here this
ratio.
is how you calculate the value. What is PF ratio in this case? You have to calculate and say the number here. So 68 is the PaO2, 60% is the FiO2. So 68 by 60 multiplied by 100 it is 1.13 into 100, that is 113 is the value. So it shows moderate value because as you rightly said only less than 100 is severe. So between 200 to 100 it is moderate ARDS. What is oxygen saturation index and what is its advantage?
No, idea.
Heard about this or not?
No, sir.
No. Okay. Oxygen saturation index is the FiO2 multiplied by mean arterial pressure into 100 divided by SpO2. So in cases where you are not able to do an ABG and get the arterial oxygen pressure or tension, you can use the pulse oximeter saturation. You try to find out the severity of hypoxemia. So this is a newer thing which has been added to the treatment where you are not able to get. So since SpO2 is non-invasive and continuously available, easier to use if PaO2 is not available, and that is the advantage of using this formula instead of using the PF ratio, which is definitely requiring the ABG to assess the PaO2. What are the components of LPV? What is LPV?
Lung protective ventilation.
Protective ventilation. So what are the components of that?
Use low tidal volume, approximately 6 ml per kg predicted body weight, and we have to maintain the plateau pressure of less than 30 centimeter of water, and we can accept permissive hypercapnia, and appropriate PEEP has to be used, and
Very good.
lowest FiO2 to be used.
Very good. Low tidal volume 4 to 8 ml of ideal body weight. Optimal PEEP, strict pressure limits that plateau pressure less than 30. Alveolar recruitment maneuvers, controlled FiO2, mechanical power limitation. These are all the components of. What are the non-ventilatory strategies in the management of ARDS?
Prone positioning, it helps, and
No, that comes under part of ventilatory management, prone position. The question is non-ventilatory strategies.
corticosteroids.
Corticosteroids. So the non-ventilatory strategies means it aims at reducing the inflammation. Because ARDS they say it is a part of inflammatory response at the capillary
Recruitment
alveolar.
manual, sir. Recruitment.
Recruitment maneuver is also part of ventilatory strategy.
Yes, sir.
So non-ventilatory, minimizing lung injury and optimizing oxygen delivery is the aim. That is achieved by first fluid management, conservative fluid strategy, or albumin and furosemide strategy. You can infuse albumin and give furosemide to remove the extra lung water. Early neuromuscular blockade and sedation. Adjunctive pharmacotherapy like corticosteroids and inhaled pulmonary vasodilators. Can you name any drug which produces vasodilatation by inhalation?
Bo-
Night.
Bosentan.
Nitric oxide and epoprostenol. Okay, these are the two pulmonary vasodilators. Why these patients develop pulmonary hypertension?
Mm,
ARDS patients can develop pulmonary hypertension. Why? What is HPV?
Hypoxic pulmonary vasoconstriction. Due to
Because
that,
of
they develop
hypoxemia, the vessels go into spasm, a
Yes, sir.
natural protective mechanism. So that produces severe pulmonary hypertension. Okay? And metabolic optimization by treating triggers, minimizing metabolic demand and adequate nutrition. And lastly, extracorporeal support. These are all considered as non-ventilatory strategies of management of ARDS. What is being done here?
Right. Hypothyroidectomy, sir.
It is cricothyroidotomy, also known as front of neck access. What is the indication?
In case of cannot intubate, cannot oxygenate.
Very good. It is Plan D procedure for can't oxygenate or can't intubate cases scenario. What are the contraindications for doing this?
In pediatric less than 8 years. Any infection or
For
surgery
children
around
below
this.
10 years, you should not do that. And there is a mnemonic called SHORT, which is shows the contraindications. Surgery, prior neck surgery, hematoma, obscuring landmark, obesity, radiation, creates fibrosis, tumor, and trauma. In all these conditions, you may not be able to do this. What are the instruments needed to do this? Already you are seeing one instrument here.
Scalpel, sir.
What blade? The blades have numbers, you know.
Yes, sir.
Surgeons may ask you, give me 10 blade, 11 blade, 12 blade. So 11 blade scalpel, tracheal hook, dilator, tracheostomy tube, and cuff 6 mm EP tube. These are all the things that will be used. A 78-year-old male who has undergone hip replacement for fractured neck of femur develops POCD, that is post-op cognitive dysfunction. What are the triggers of POCD?
Advanced age. Advanced age.
Hmm.
And preoperative cognitive dysfunction is also a trigger. And improper analgesia.
Inadequate analgesia, not improper.
Inadequate analgesia.
So
And
usually we have a mnemonic to remember that, which is called DIM talk. Okay? The D, drugs or toxins. I for infection. M for metabolic, that is hyponatremia or endocrine disturbance. T for trauma or thrombosis. O for hypoxemia or oxygen deficiency. P for pain and psychological. So these are all the 6 reasons for that. Name one screening system to assess cognitive function and its components.
toxin, mini mini mental status exam.
Mini mental state, very good. That is one. That, but it's a little long. It takes about 15 to 20 minutes. So easy to remember is what is called mini cog quick 3-minute screening tool. Mini cognitive. Cog is short form for cognitive. Mini cog is, and the components of that are three-word registration. That is, you tell the patient three unrelated words like banana, classroom, no, shirt, pant, something like that. And then see whether the patient can register those names. Then you give them a paper and ask them to draw the face of a clock and mark all the time from 12 to 1 to 12. And then ask them to draw the small hand and big hand for time. Commonly 11 hours and 10 minutes. They have to draw the. And third thing is three-word recall. After you have told the three words, you ask them to repeat them after giving them over, distracting them with this clock for 5 minutes. You ask them to repeat the three words. If they are able to do that, that cognition is good. So three-word registration, clock drawing, and three-word recall. These are the three components of mini cog test which can be done in the pre-anesthetic checkup time. How to prevent postoperative cognitive dysfunction? Earlier we
We
saw
have
these are
to
all the triggers.
preoperatively optimize the medical conditions
Hmm.
like diabetes, any cardiovascular abnormalities, and we have to maintain oxygenation.
Hmm.
And the cerebral perfusion has to be maintained and the blood pressure to be maintained.
Right.
Early
So
mobilization.
baseline cognitive assessment, preoperative management of comorbid conditions, avoiding prolonged GA, appropriate hydration, prevent hypoxia, sufficient pain relief with minimal opioids, early mobilization, cognitive stimulation, adequate sleep, minimizing sedation, avoid delirium-inducing drugs, restore their aids, which again I am insisting, and by patients like specs, hearing aid, dentures, walker, etc. Okay? These are all the methods by which we can prevent post-op cognitive dysfunction. What is seen here?
Jaundice.
Jaundice. Yes, you are right. Jaundice exhibited in the eye. Why? How is it exhibited in the eye? What happens? Why do you get this yellow discoloration?
Due
Bilirubin
to
gets
increased serum
deposited.
bilirubin.
Bilirubin is deposited where?
Sclera.
And
Huh?
mucous membrane.
Mucous membrane.
Sclera.
Sclera.
In the eyes, it's sclera, sir.
It gets deposited in the scleral layer. Okay, not on the conjunctiva. It is because conjunctiva is transparent, you are seeing it, but it is deposited actually in the sclera. What are the various shades of yellow based on the type of jaundice? Like pre-hepatic, hepatic, and post-hepatic. Will there be a difference in the shade of yellow you get? Is there any description for that?
Lemon.
Yeah, lemon yellow, orange yellow, and greenish yellow. Pre-hepatic, you will get lemon yellow. Hepatic jaundice, that is intrahepatic jaundice, you will get orange yellow. And post-hepatic, you will have a greenish yellow.
Greenish yellow.
Because it contains both the conjugated and mostly conjugated bilirubin. What are the parameters used to calculate MELD score and why it is used?
MELD score, serum bilirubin, INR, and
Serum
creatinine, sodium. Sodium in MELD, na, sir, actually. In MELD, it's used to assess severity of chronic liver disease to prioritize for liver transplantation.
Very good. Score is used to identify the recipient who will be benefited by early liver. What are the risk factors for hepatorenal syndrome? What are the triggering factors?
It's due to a dehydration, sir, or due to spontaneous bacterial peritonitis.
That is triggering factor.
Yes,
The
sir.
risk factor is in which
Cirrhosis.
type of patients you get HS?
Cirrhosis.
Cirrhosis, portal hypertension,
Yes, sir.
decompensated liver diseases. Okay, so the acute
Yes,
liver
sir.
disease, these are all the people who will get this. The main risk factors are advanced cirrhosis, portal hypertension, and acute liver failure. And triggered by severe bacterial infection, that's spontaneous bacteriosis, GI bleed, large volume parasitosis without albumin replacement, the use of nephrotoxic medications like NSAIDs, etc. Okay. That is the end of the Osce questions for this week.
Yes, sir.
Shall we sign off?
Yes, sir. Thank you, sir.
Yes, sir.
Thank you, sir.
Thank you very much, sir.
Thank you.